As I said, I've been in emergency care for the best part of 24 years and been a consultant in Antrim since 2000. When I started in Antrim, our department would have seen about 39,000 new patients. In a department at that time that would have been probably 6 years old, that was built for 37,000 patients. We now see 78,000 patients, and it was only up until this time last year, actually June last year, that we have moved into a purpose-built unit that has actually been designed for about 90,000. If we go back a bit, since about the winter of 96, 97, trolley waits started. And when I describe trolley waits, these are the large numbers of patients who, after being seen, diagnosed, and treatments have commenced, wait for admission to a bed on the ward. This holding of patients has stretched our staff, and the emergency department has become the ward with the elastic walls. We have had no control over the patients coming to the emergency departments, and we have no control over those moving out into the hospital. The capacity for holding these patients has had a direct impact on our core work, which is to deal with emergencies in a timely manner. In England in 2004, in the English NHS, the 4 and 12-hour target was introduced. Prior to the introduction of these targets, there was investment in infrastructure and staff, both within the IT systems, within the building, and they were able to set up staffing structures because they could see what was coming. None of that occurred here. There was none. In spite of those targets of the 4 and 12-hour, the 12-hour was, I have no problem with those targets. It was great for the patient journey, but there would appear to have been no improvement in clinical outcomes around the 4-hour targets. At that time, no quality measures were introduced, and the focus was purely on the 4 and 12-hour target. No other timeframes and standards were put on the rest of the system, just on the emergency department. So in the emergency department, for the patient and for us, it was hurry up and wait. With our senior managers and senior nurses, we've had to put in place quality standards, governance structures, taking into account patient experiences and complaints. We've had to develop systems to try and ensure patients were safe. The Royal College of Physicians' mantra of right patient, right place, first time has never been effectively implemented. It would appear that the emergency department, as a receiving area for all patients, has become the norm. This has led to challenges, in particular around staffing, resources, and dealing with patient expectations. The emergency department is for emergencies, not the hospital's main entrance. Pressures from the back of house and outside within the community have impacted severely on the emergency department. Lack of services out of hours has created problems. When I talk about out of hours, I'm talking about 2/3 of the week that is left after the 9 to 5 of Monday to Friday. Mm-hmm. This has resulted in crowding. I'm proud to work with a team that has one ethos, which is to try and do the right thing. To do this, we have to be experts in making difficult decisions with limited information in a timely fashion. This can be challenging. The best of us try to involve the patient and their families in these difficult decisions. At times, there's no right or wrong answer for every patient, but we try to get it right. However, we are stretched to the limit. Unscheduled care remains a Cinderella to elective care. The whole system approach required to solve the problems have been difficult for some to address. For others, it's very difficult for them to understand. There will always be demand that outstrips the supply. We work for people, not for targets. Initiatives and investments come and go, but the demand keeps rising. I work in a specialty that will always be needed, that is always changing. The public turn to us when they don't know what to do or they haven't got the answers they want. When they're in crisis, they come to us, the emergency department. Thank you.
Okay, thank you. Mark, I think you've very eloquently outlined, frankly, the challenges and also the need for a whole systems approach, and that you can control to a limited extent what happens within the emergency department, but what comes in through the door is outside your immediate control, and what goes out the door, where it can go to, is also outside your immediate control, and I clearly understand that. And I suppose then what I really want to ask is that we heard earlier about some initiatives about tackling that, and there's been a well-publicised kind of acceptance of difficulties within the Northern Trust area. So how are those working on the ground? Which are the things you think are working and making a difference? Which are the things you think really still need work upon? So to get a feel from all three of you about how the changes that have been implemented are working in practice on the ground.
Okay. Linda, do you want to start first?
We have spent a considerable amount of time reviewing our systems and processes, looking at how we can move patients through a pathway that doesn't rely on one door being the emergency department. We have introduced an assessment unit where GPs or other clinical professions can refer directly in to be seen by someone from the in-house clinician teams and therefore taking those groups of patients away from the emergency department. Other teams like paediatrics have established ambulatory streams. Gynecology team have developed rapid access clinics. All of those schemes have assisted in us taking some patients away from the emergency department and getting them to the right clinician to see them first time rather than being seen by a ED clinician for a further assessment, bearing in mind these people have already been seen by a health professional. So these patients, we have attempted to reduce the amount of contacts for them that they've had and getting them to the right person. And that has actually been very successful. Our in-house medical team have spent considerable time reviewing their working practices and introduced initiatives like very early morning ward rounds where they review all the patients that have come in the previous night, and all patients are assigned to the specialty regarding their condition. They do evening ward rounds, and they also, we've increased the number of consultant clinicians that come in at the weekend. This helps, the pathway of the patient, senior decision-making reviews, and also helps support timely discharge and thus freeing up the beds. Our biggest challenge does remain the availability of beds on Antrim site, and a very comprehensive piece of work we did with the turnaround team, and I know the executive team mentioned that this morning, was to in-depth look at our bed requirements for our patients, and they have identified that we do require more beds. This is particularly challenging for us at times of peak demand in beds, like in the winter, and the lack of required bed stock, I think, across the whole site is our biggest challenge. We have, in terms of successful things, we some time ago, we commenced morning site safety meetings. They occur at 8:30 every morning, where everyone from right across the whole site comes together. That's every ward, every department. It's not just clinical departments, estates, support services all come and join us. Representatives from each of the clinical teams, so physio-dietetics as a couple of examples. Everybody comes together, and we look at the present situation. We look at how we've maintained safety and standards of care over the previous 24 hours, and we look ahead at what our demand is going to be, what our challenges is going to be for the next 24 hours, and we put escalation actions in place to assure ourselves that we can meet those challenges in the most safe way that we can do. That has had significant outcomes for us. We have seen discharges planned and facilitated earlier in the day. We have seen communication with our community colleagues around elements like packages of care, intermediate care beds that patients would need to be safely discharged or have their care transferred. Those meetings would be recalled again around lunchtime if we felt that the situation was still of concern. And I think that has supported the flow and the availability of beds out of ED much more than we had done previously. It has not totally, answered all our problems. We still have delays in patients leaving ED and waits in ED contributing to crowding, which is in excess of what we would want. But it has helped us to a considerable extent, and it has brought the whole site together, and it has given an ownership of attempting to meet the demands of our patients coming through, and keep a focus on safety and working together.
Bringing it down to probably a departmental level, we have seen the nursing staff take on more, extending their roles. Examples of this would be nurse requesting x-rays, administering analgesia under patient group directives, front-loading of investigations so that we can actually shorten the patient journey. We have a mental health pathway so that patients who present a triage, we can refer directly to the mental health team, we can refer directly to gynae. We have a dedicated paediatric area that is staffed with paediatric trained nurses, so the experience for paediatric patients within the department has definitely improved. We are fortunate that we do have a brand new department, and along with that we do have a 10-bedded observation unit where we do have pathways where patients who present to the emergency department can be cared for by the emergency consultants, because there are some conditions that if they're cared for by emergency consultants, we can actually shorten their length of stay in the hospital. We also have emergency nurse practitioners. These are specially trained nurses who will assess, treat and diagnose patients who present with minor injuries and illnesses. Within Antrim site, our emergency nurse practitioners work very hard. They see over 20% of the patients that attend with these type of injuries and illnesses, and this helps allow the doctors to focus on patients with more serious injuries and illnesses. We also have we are fortunate that we have actually a lot of support staff within the department, from domestics, from clinical administration staff, patient trackers, and all these sort of initiatives have allowed us as nurses to release us to actually care for our patients.
We've heard of some of the initiatives there. Maybe some more of the quality type things. Certainly we've been blessed with a new department last year, of which one of the big areas we were able to satisfy was a paediatric area, standalone paediatric area, separate from adults. I think you've heard earlier about the initiative of having paediatric nurses coming up. It has been one of the big successes for the children, is that they come away from the main areas to their own respective areas, and we've been able to forge better links. We've already had very good links with the in-house teams, such as paediatrics, so we've been able to forge that. One of the other initiatives was a mental health pathway that one of my colleagues she was a member of a regional group that has developed a mental health pathway, which we have really taken on board, starting at triage, really almost avoiding the contact with the doctor. We've got a very good safe sheet to fill out if the doctor is required, they are, but we also have very quick access to our crisis response teams, who are effectively our psychiatric liaison service. So as well as being a risk assessment tool for them, it has actually helped also as a triage tool for ourselves. So for quality for those two subgroups of patients, it's actually been what we think has been very good initiatives.
And in terms of what you'd see as the kind of still the key outstanding issues that need work on, what are those things that still need work on? What are those key areas?
Yeah, do you want to?
I think if we go back to looking at what the fundamental core of an emergency department is really for emergency care. And a lot of colleges, I made mention of one, the Royal College of Physicians, right patient, right place, first time, has to be the crux. Rather than having me in the middle of a pathway of somebody that obviously needs help or needs to be seen by a specialist, there are ways that it can be diverted. If you funnel everything into one conduit, which is the emergency department, you're going to have queues. Unfortunately, that's just the way it is. We're not Tesco's. We can't call on lots of multi-skillers over Christmas and open 20 portals. We have what we have, the resource that we have. At best, we may have 5 or 6 doctors. Therefore, with each patient being received by one of those doctors, you would say that within that time, those 5 doctors are taken up very, very quickly. But if you've had 15 arriving, you're going to have to start queuing.
Mm. And can I ask, in terms of sort of right place, right time, there's obviously an issue of educating the public and understanding services and what they are. We've had some evidence from the Patient Client Council. How about actually, though, other healthcare professionals? Do you find, for example, that GPs understand the various different pathways that operate? Or are there other healthcare professionals who need educating? Or do you find that a seamless process that GPs don't send people to the wrong place at the wrong time?
Do you want me to begin? No, we wouldn't find that they always send patients to the right place. GPs are very busy individuals as well, and we have done a lot of work with our GP colleagues, and in developing the assessment unit, they very much were part of that. In fact, the group was co-chaired with the GP and myself, so we were keen to engage with them right from the beginning through all the discussions about its inception, through into it being operationalised and evaluated. But we still, in putting in all of these access routes, we do still find that the GPs would refer somebody directly to the emergency department when their pathway could have been shortened and got to the right place. I think that puts responsibility back on us as well, though, in terms of opening up those arenas where we can work with our GP colleagues, and keeping reminding them of the facilities that we have, and develop them in conjunction with our colleagues. So yes, while I would say there's still a lot of discussion to do, there is still a lot of understanding out there to generate among primary care. I think that if we do that together, that's where you begin to get meaningful services being developed.
Okay, and my final question before I hand over to Marion is, and kind of in the light of transforming your care, I wonder, are there any initiatives within the Antrim Hospital in terms of how you liaise with the social care sector, so how health and social care is joined up? And I'm thinking both in working hours but also outside of working hours. And if there are, can you tell us a bit about those initiatives?
Yeah, if I pick that up. One very conscious element of planning in the Northern Trust was that hospital social work actually sit with the acute directorate. That was to ensure a very integrated planning, for patients' assessment and discharge. We have, I believe, a very good working relationship with our colleagues in community. They do come onto the site each day, somebody from the intermediate care team. They look at all the patients that are current and are about to become well to be discharged. And they work with our in-hospital social care staff to actually plan the patient's discharge. So I think that in reach from our colleagues in community and working with our community social care colleagues and our hospital social care colleagues has actually smoothed the pathway for patients to be discharged safely and timely back home again.
Okay, thank you. Marion.
I have two questions. One on responding to particular needs of some client groups and the other one on workforce planning. And I'm just wondering, you've already outlined the improvements in the ED journey for children and those who are mentally ill. And I'm wondering, for migrants or those with a learning disability or dementia, could you outline the patient journey? Any problems you've identified in terms of identifying those people's needs and treating them, and any suggestions you would have for improvement?
I think the group that you've hit, the dementia group, we're seeing that with the changing demographic. The frail elderly, I'd even put them in with that dementia group. We have tried to put in a number of simple initiatives with them, or even some would just say even common sense. With those groups, it can be a very scary experience, it can be very confused. We have really tried to reinforce that carers and relatives are welcome with those patients. In spite of the busyness and we do try and have some control over the number of people within the department, because at times it can be difficult to say who's the patient, who's not. But for that group, we do appreciate that we do require them to have their carers that bit of stability, that bit of that recognised space in a place that is really can be quite frightening. Bright lights, lots of noise. So we do have that. We do have the pleasure of having the single rooms. So that can limit the noise, limit the hustle and bustle, so they are there. Though I would say that we have found that some people find that quite isolating. With the doors, it's amazing. Some people we can see, we can understand the need for that, but some people have actually turned around and said, I thought you'd forgotten about me. I feel isolated here. Although we do have named nurses, we do have people patrolling, looking at those areas. If there's any what we're putting in place, actually, our own college has recognised this, and they've actually put in one of the College of Emergency Medicine's audits, which the vast majority of us have signed up to, and we've signed up to them for the past couple of years, as one on cognitive behaviour. So we have actually just started that, believe it or not, this week. Not because of this, but because that was a time frame, and that had come through from our college. We have, across the trust, there's a scheme called the Butterfly Scheme, which, Linda, if you want to...
Well, one of our colleagues mentioned about that this morning, and I think for our clinical staff and the emergency department staff were very engaged in developing that, because it's to the emergency department that patients first come. They've been taken from their home environment, and it can be an extremely, as Mark said, noisy, busy place, and very upsetting for patients with dementia, very upsetting for their carers who are with them. And the Butterfly scheme in early recognition of dementia has been, I think, a good success. We've also done a considerable amount of training with our staff in relation to recognising, but B, how to care for patients with dementia. And we do try, and I say try because sometimes other clinical priorities, we do try to expedite patients with dementia through the system. It is not always possible, dementia champions. I think we have a number in the emergency department. I think they've made a significant contribution, and I know all have mentioned about those this morning. Lindsay, do you want to mention anything about?
We do have timely access to interpreters, and we will use them to ensure that we can communicate effectively with our patients, and the ongoing work with regards patients who attend with learning disabilities. Again, we have got an amazing environment to care for patients. As long as our department does not become crowded, then it becomes difficult.
Thank you. Looking to workforce planning, in terms of the skills mix, doctors, nurses, allied health professionals, support workers, how are plans made for that skills mix? Are you confident that you have the right skills mix? Do you have any suggestions on how to improve it for the future?
I suppose from a nursing point of view, from a nursing point of view, regionally and indeed nationally, we don't have a recognised workforce planning tool for emergency nursing, and this has been difficult to justify why we need the nurses that we need. Professional judgment sometimes just isn't enough. We do recognise and appreciate the work of the CNO and NIPEC in their normative staffing levels, where emergency nursing is the focus of phase 2. From a medical point of view,
I think we probably don't have the right number or the right mix of staff. One of the issues about staffing hospitals within emergency medicine is consultants and associate specialists can be the ownership of the hospital, if that makes sense, because they're like service grade, so the hospital has some control over how many of those they wish to appoint, how many they can have. We're also a training environment for our junior doctors. That training, those trainees are allocated centrally, which is out with the control of the trusts. So we get what we get from that central allocation through NIMDA, Northern Ireland Medical and Dental Training Agency. So unless they get a vast influx of money into that pool to then pull people in, we see no big increase within that. I'm sure you already know that staffing within emergency medicine is difficult, not just here but also within the UK. There is a national issue about that. As demand has increased, we see very small increases in our staffing, but we see the demand is forever demanding, and one or two doctors is just playing around the fringes of it all. Again, there is no accepted number of how many doctors you should have for that service. And ultimately, with the resource you have, you max out the ROTAs within the European Working Time Directive and the junior doctors' hours and all the legality around that. You max out what you have consultant time, but you've just got to accept that those numbers have to change, have to vary.
Care, assessment and treatment intervention care in emergency departments has traditionally, been delivered by medical staff, and we've known for a little while now about the workforce challenges in relation to medicine, and I think that should give us the impetus and the need to actually look at what other roles need to be brought into emergency care. I think we've looked in nursing and we've introduced emergency nurse practitioners. We're looking at advanced nursing roles. I think other health professions. There's pharmacists within the emergency department. All of those other roles contribute to the requirements of the overall need of the department. Administrative roles are extremely important. Having introduced the patient tracker in the emergency department, who actually, while clinical staff are delivering clinical care to patients, they're checking his blood results back, all of those things, ensuring that relatives are being given information and things like that. Looking at roles that can free up clinical staff, but also looking at new roles, and my colleagues from other professions mentioned around physio practitioners and things this morning. We really do need to think, who can deliver what elements of care, who can best deliver to the patient, and recognise those and start developing them and planning and commissioning for those new roles in the future, because the medical workforce will be a challenge for some time to come.
Who would lead that sort of strategic workforce plan that you're talking about, which would include all of the professions and the support staff and admin staff who work in ED?
Yeah, I think in Northern Ireland of its size, we could actually, look at it regionally. I think it's important for all those who are leading professions and commissioning the management, of the service, to actually do it collectively with representatives from each of the trusts who know the local needs, and experts from the field of emergency medicine who know, the changes to practice that are required and coming up. And
thank you very much. Thank you.
Paul.
Thank you very much for your help this afternoon. May I ask, in your contracts of employment, is there what is known publicly as a gagging clause? That is there a clause which says you may not publicly criticise your employer?
No.
There's been some discussion about gagging.
Oh, right, okay. Yeah. Obviously, we've quite clear document confidentiality clause, in relation to patients, but no, not gagging clauses.
Okay, thank you. Morbidity and mortality review processes. Are you personally involved in those? Anyone?
Yeah.
We have, for the past couple of years, we've had monthly governance meetings, which have all been documented. Within that, we have looked at complaints, SEIs, and occasional cases. Over the past few months, we've firmed that up with other teams, where we now have a regular M&M looking at the deaths, and looking at each month, looking at maybe different groups, maybe looking at sepsis, ones that go to the ward and go, well, why was ICU called an hour after they went to the ward? Maybe they should have gone straight to ICU. That it sort of highlights some of the issues that may not have been apparent. So we do those on a regular basis. The governance meeting has been probably the most useful of them all, because it brings in so much information. And from that information, we've been able to help out with these chem audits I mentioned earlier. We've fed into a lot of those, of which there was the sepsis, there's been pain relief, things like that the college have set up, which we've always fed into. But from the things that we've identified, particularly within the sepsis, we have set up M&Ms, usually with colleagues that anaesthetics would be the obvious port of call for us, because they're going from, I suppose we're a high-level area, or a resuscitation area is high-level, so it seems obvious that you go from one high-level area to the next, which is obviously intensive care. So along with the ICU and with the surgeons or the physicians joining in if there's been any of those deaths.
You mentioned the adverse incident reporting in your remarks, and I was interested to read in the latest report of the board and the PHA about serious adverse incidents. It's the latest report of June 2014, and right at the end, it's the penultimate paragraph. It says that the board and the PHA have revised the SAI documentation to include a checklist. Excuse me, let me start a little earlier. They've recognised a need to enhance service users' families' involvement in the SAI process. So it's only a few months ago. So, and they say that the documentation is going to be changed to sort of try and ensure that where appropriate, sometimes it might not be appropriate, but where appropriate, families are involved. And I'd be interested to know, not whether you've already actioned that would be unrealistic, but I'd be interested to know to what degree, in your experience, families have been kept involved in the SAI process.
Okay, Jim. within the Northern Trust, when an event occurs that is reported, as I said, we straight away would advise the families that we are going to commence an investigation through the serious adverse incident process. So it's important for us that right from the beginning they're aware of that, and we would give them a specific contact. So there will be one individual who will remain in contact with the family. That's important because sometimes it can actually feel that while we're undergoing our investigation that everything has gone quiet. So it's important that there's a system of regular contact, but also that there is an individual that they can just lift the phone and ask for an update. We then share our findings with the family. We invite them for a meeting to go through, and if they so wish to take that up. Some individuals would actually say, no, I would just prefer you send me the report, and then we'll arrange a meeting to identify, they'll identify questions. So whatever, it's important that we respond to the family in whatever way is best for them to hear the information and ask questions.
Thank you. I have a question now which, if I'd had time, I would have asked this morning to your colleagues, and it might be you don't wish to reply. That's fine. If there were time, I would have asked it this morning. But in the same report, there's a table of the SAIs reported by organisation, and for the period October 12, March 13, there were 48 SAIs in relation to your trust, and that then doubled in the next 6 months. It went from 48 up to 98 in October 13 to March 14. It's a big increase. And when I look down the numbers for October 13, March 14, the NHSCT is easily the highest. There's one other at 70. So there's 98, that's your trust, and then 70, and then after that it's 47. So it is quite a standout, outlier figure. And I want to emphasise that doesn't mean that there's a particular problem in your trust. So don't misunderstand me. But it is interesting data.
Yes.
So I'm not suggesting there's anything suspicious or anything like that, but I'd be interested to know your comment on that. Pick that.
I think we did spend some time, a little while ago, looking at our processes, and I think that we changed those and communicated those changes very successfully throughout the organisation. And what I think we seen was not an increase in events happening. What we seen was a much more robust process, and us identifying, reporting, and commencing early in investigations, making I believe the organisation much more open and transparent in how we identified these.
I think the culture of openness, I think, is that's what's being reflected there with all the training and all the processes that have been put in. But I think there's a culture of openness that's coming through, and that's what you're seeing with those rising figures.
And that's why I was careful not for it to be seen as a contemporary criticism. It might be a sort of retrospective criticism because it implies there was perhaps some underreporting or lack of equivalent transparency in years gone by. But it reflects progress. That's what you're saying.
It does.
Okay, thank you for that. I'd be interested to know to what degree, if at all, the three of you are included in the commissioning process for your trust.
Okay.
Well, you can talk about your side, and I'll talk about the medical side.
In terms of unscheduled care and commissioning emergency care, I am not sure that we would all feel that has been as robust and systematic as it could have been, as it should have been, so therefore I think as we move ahead, it's important to look to the future and ensure that we do have a much more rigorous process for the commissioning of emergency care and engage with the commissioning of that. So I would have to that. In terms of commissioning lots of other services, there is quite a planned way of meeting with the commissioners, identifying developments and service challenges, and working together to commission what those services might be. I think maybe in the past that we have focused quite a lot on the more planned elective side of things. I do absolutely get a sense now from the meetings we've had with local and regional commissioners that there is a much more of a desire and identification of need to actually think about how we commission the more unscheduled side of our service. So I would say that I'm optimistic as we go forward around engagement in commissioning, that maybe just hasn't been as rigorous in the past.
Thank you.
Could I just add to that? I think I sort of alluded to that in my opening remarks.
Yes.
With that unscheduled care has been the Cinderella. They always said emergency medicine was a Cinderella specialty. We didn't actually realise that the whole system was a Cinderella in the system that is set up. And I think one of the things that the commissioners are finding very difficult to get their heads around is how to address this. Elective is very easy to have robust processes, there's facts and figures, there's numbers there, X amount of operations happened, I paid for that happens. Unscheduled is a very different beast. Some of them have found it very difficult to address, and I might add, some of them are finding it very difficult to understand. And that has been the problem. Personally, I'm not involved in commissioning. They don't sort of come to the grassroots to hear or see some of the initiatives that we think could make a big difference. But I do appreciate that they have to balance the resource that they have, especially in the times that we're in just now.
But I find your comments really, apposite and interesting. And if it comes to, or when it comes to sort of measurement of performance, which is what the commissioning board will be interested in, how are they to measure it? From a human rights point of view, which is one of the things, obviously, one of the things we're interested in. Numbers aren't enough. Numbers don't tell the full story. So one needs other sorts of measure and perhaps qualitative measures. So and that takes us into a new terrain.
Yes.
So I'm just trying to get a sense of whether that adjustment is likely to be made. But I note your comment. But it is a challenge for everybody, including the commissioning board.
Yes.
May I ask, have you met the Equality and Human Rights Officer? I believe the Trust has one. Have you met the Equality and Human Rights Officer?
Yes.
Yes?
Yeah.
I'm trying to think of it.
No, I'm still going through my
Right. And Mark?
I'm useless with names, so I'm sorry. I just
You don't know.
I can't.
Okay.
I don't know.
And my questions aren't adversarial. I'm just trying to find the information.
Yeah,
Yeah.
sorry.
So has there been, for instance, a human rights training for those in ED?
Yeah, in the Northern Trust there is human rights training, and the staff in ED can access that. I think at times of challenges around that, we do constantly have a challenge with releasing staff to go to training, and we would, as we move ahead, we have looked at training and in the department, and not just in relation to human rights, but all elements of training, and Lindsay and her colleagues have worked very, very hard on a training plan for the emergency department. We have introduced training roles in the emergency department, so that all of that is coordinated, and a significant number of staff have actually attended the human rights training. So, do you want to comment on?
No, medical would be very similar. It's interesting within the training. It's very simple for the clinical training. It's this non-technical skills of which some of the human rights things are. I think is a challenge within the medical model as such. But certainly, I know that we've encouraged people to go to London Deanery. Has been very good with certain online modules and things, and we've really tried to push that resource, or try to find resources to try and push these non-technical.
I'm not going to make a long statement about this, but very, very briefly, it seems what we've heard is there's huge overlap between your guiding principles in your work, in your professional work. There's a huge overlap between that and a sort of human rights-based approach. And we're not seeing human rights as something sort of other or outside or oppositional or different, but rather a way of reinforcing some of the fantastic work that you three and all your colleagues are doing. So that's how we're constructing human rights, rather than sort of just a compliance box, rather something that can help you in a modest way realise your professional objectives. I think my last question, you might have heard it earlier, it's the larger issue about public participation in the health system. And it's a tricky one, this. But from a human rights point of view, human rights puts a premium on as much participation as possible, and there are limits to it, right? And we shouldn't have a romantic, rosy view of participation. But there are limits to it. But human rights does put a premium on as much participation as possible in governance of a health system. And the participation can come from patients and their families, it can come critically from health professionals, and you've talked a bit about that, that's been really interesting, and also participation of the public. And as you might have heard me say earlier, there are already mechanisms for public participation in the health system, including in ED, through 10,000 Voices, through the PCC, through patients' users groups, and I'm just trying to get a sense of whether or not you feel that public participation could be enhanced further in some way. And if so, how might that be done?
We have, when we had the new build, we had all the patient groups. We took that on board, an awful lot of what they were saying. Certainly for doctors with revalidation now, patient feedback, we all have our forums. Yeah. We all have to do that every 5 years, which has actually been an eye-opener for some. For others, it's just reinforced what we thought we were doing anyway. We have made use, particularly of the new areas, where we're quite keen to investigate how the paediatric area was working. And I'm trying to remember how many, it was about 200 responses of paediatric patients. We had a big SpongeBob SquarePants, and they fed in their questionnaires, and the feedback for that was really quite important to us. It was reassuring to the staff, because they were working quite hard with our resource to staff a separate area. But the feedback from the patients was really very welcoming. I'd say it just reinforced what we thought was to give a good quality service to them. Do you want to add in anything?
No, all patients and their relatives really had the opportunity to feedback within the trust, with regards to complaints, compliments and feedback.
It was more the public participation. Excuse me interrupting, Lindsay. It was more the sort of public participation. Patients, families, really important. Yeah. You people, really important. And it was sort of community participation.
Well, the one we used to have We stopped it recently, but we had the Well Teddy Clinic. Don't know if you've heard. They aren't patients. They're usually 5-year-olds. They all come with their teddies, and they're taken through a patient journey by one of our nurses with an interest in peds, so that it takes away the fear of when they are, because of the area we cover, that is undoubtedly the vast majority of them will come through our doors at some stage. It takes away the fear. We worked with that with the local primary schools in rotation coming through, so that they got rid of the fear. They were taking the patient journey. They saw what an X-ray machine was. They heard the noise of the X-ray machine, just to alleviate that. And the feedback from the primary schools, actually there was a waiting list of primary schools that were wanting to participate in that initiative.
I just come in. I think we locally within the department there has been several initiatives about getting feedback from patients. I think that where we can expand and gather is from the community. The chief executive identified this morning about his vision for going out and about and getting community involvement and getting their perception and view on where the service needs to go. And I think there is so much more we can do in relation to that. We have, as professionals, concentrated in getting feedback from patients and their relatives or carers, but as we go strategically into the future, what does our community want? And I think that there's a lot we can do to get that information so that it's included in how we are developing our services for the future. It's absolutely the right thing to do.
And do you have any thoughts on how that might be done, preliminary ones, or maybe you need to think about it?
And I need to give it more thought, but I think there is lots of patient representative groups out there that I think we could improve our liaison and communication with. I think having public meetings with community, going to small communities and having public open meetings with them, as we are the team who are actually at the moment delivering your healthcare service. How can we help you, and how can we do that better for you? What is the things you want us to look at for the future, and that that gives us the opportunity again for a two-way exchange. Saying, well, this is how you can help us as well to deliver a better service for you, and giving some information around how our community can best access our service, but best use them as well. So that would be some initial thoughts on it.
Do you think the non-executive directors of the trust could play a role, or is their function somewhat different?
I think their purpose is to look after the needs of the community and challenge the executive team and all of us who actually deliver service. I don't see that being exclusive to their role of going out. And yes, I think they could be involved in that.
Okay. Thank you all very much.
I have one final question, and it's for a very quick answer, and I'm conscious of time. To each of you, really, if there were two things that could improve your role and your service within the trust, what would they be and why? And
Two
very
things
briefly.
that would improve our service. I suppose my wishes are quite aspirational. I would like us to provide a safe, person-centred service to every patient that accesses our service. And I would like us to have, therefore, the resources and the infrastructure and the environment to do that. And the second thing I would like is to increase the public confidence in our service. So our service is such that the public has a much greater confidence in it.
Okay.
My two wishes. greater investment in our nursing workforce. Nurses do have some of the solutions, developing advanced nurse practitioner roles, the expansion of nursing skills, but we are stretched. We have taken on loads. We do need that extra resource given to us to be able to develop more. And again, it's making sure that the public have confidence in us and getting that confidence back, because it has been dented over the past while.
Okay. Falls to you, Mark.
I wish I had some all-encompassing. Unfortunately, I don't.
These can be relatively minor. They don't have to be kind of transformational.
Just one thing, Rowan, too, just one. If unscheduled care was taken on the same par as scheduled care within the systems approach, you might find a lot of the problems are sorted.
Okay. Do you want to exercise your right for a second? You can't have three wishes, you can only have two. Okay. Look, that's really helpful, thank you. Thanks for your evidence this afternoon. It's at the late end of the day, so appreciate the time you've given up at the end of a busy day, and some of you I know have been here for the afternoon. As we've said to others, including Chief Executive and your other colleagues who are still here, if you want to augment or think we've missed anything, we're happy to take additional material from the Trust, and any further written submissions will be very, very welcome. And thank you, it's really useful to get a sense of, from those who are, if you like, managing the service close to the ground, the view of what's happening. So it's been really helpful to us, so thank you very much.
Thank you, we appreciate it.
Yeah.
Thank you.